evaluation and treatment of the rib component of the thoracic cage should follow the appropriate diagnostic and manipulative therapeutic approach to the thoracic spine, maximizing the thoracic spine function so that we can evaluate how does the rib on each side relate to the thoracic spine. Now the ribs are 12 in number on either side, and they are divided into what are called typical and atypical ribs. The atypical ribs are all ribs that have the numbers 1 and 2 in them. The first and second rib at the top, the 11th and the 12th ribs at the bottom. Now what makes the first and second rib of great importance is their relationship to the thoracic inlet and the neurovascular bundle as it proceeds out down through to the upper extremity. Now, the upper first and second ribs are atypical because they do not have good angles. They do have costotransverse articulations, but the anatomical thing that makes the first rib so interesting is that it has a facet and articulates with a single facet on the lateral side of the vertebral body of T1. At the bottom, the 11th and 12th ribs are atypical in that they do not attach to the sternum. Their anterior extremities are buried in the abdominal wall. They too have single facets for attachment to the 11th and 12th vertebra, and there is hardly ever a costotransverse articulation there. The typical ribs run from 3 to 10, and what makes them typical is that they attach by demifacets to 2 adjacent vertebrae, have a costotransverse articulation, have prominent angles to which the iliocostalis muscle attaches, and then anteriorly they attach to the sternum either directly by the cartilages or through the combined costal arch at the bottom. Now you're interested in the thoracic cage, its anatomy, and its function because of its influence on circulation, as well as you are interested in it from the biomechanical perspective, because circulation and respiration are dependent in large measure by function of the diaphragm. The diaphragm below attaches to the fascias of the psoas and quadratus lumborum, attaching them therefore to the lower extremities. The crura of the diaphragm attach down to the first and second and third lumbar vertebra, and the rest of the diaphragm attaches to the lower 6 ribs and the influence of those lower 6 ribs from the thoracic spine. Now because it has its major innervation, the diaphragm that is, from the phrenic nerve, that takes place from C3, 4, and 5. So there's an intimate relationship of the diaphragm to all parts of the musculoskeletal system: cervical spine, thoracic spine, rib cage, lumbar spine, and right down to the lower extremities. Remember that the diaphragm is the pump of the venous and lymphatic systems. So we're dependent upon normal function of the diaphragm, normal function of the rib cage, to assist in the exchange of the negative interthoracic pressure for both respiration and the pumping action for the venous and lymphatic systems. The diaphragm can be called the second most important muscle in the body, right behind the myocardium. Now, what we will want to do is to evaluate this rib cage in a number of different directions, but particularly for its respiratory component. Now, all of these ribs will move during respiration, and they move on inhalation, they elevate. On exhalation, they drop down again, so that the normal respiratory movement is an up and down. Now, there are 2 different components to that respiratory motion. One is what we call pump handle movement, which is as we pump it from the side, just like a pump goes up and down. And that kind of motion is more found in the upper ribs than in the lower. The other dimension of rib cage motion and rib motion during respiration is what we call bucket handle. And that's where the lateral aspect of the ribs go out in this fashion, very much like a bucket coming out, bucket handle going this direction. Now, all ribs have all components of motion, both pump handle, bucket handle, during inhalation and exhalation. But because the upper ones are more pump handle and the lower ones are more bucket handle, why we can identify that by where we place our hands on this chest wall. There is another motion that occurs in ribs, and that is the motion that accompanies turning of the trunk. As we turn right and left, the thoracic spine rotates, but it also turns the ribs. And as we do turn to the right, what will happen as the thoracic spine turns right, it turns these ribs more into an external rotation posteriorly. The superior border becomes more prominent, the inferior border becomes less prominent. Now that will be true all the way around to the mid-axillary line, and then it switches and it becomes just the reverse in front. The superior border becomes less sharp and the inferior border becomes more sharp. The reverse is true on the opposite side. As you turn to the right, the left ribs will now internally rotate posteriorly and externally rotate anteriorly. That motion is called rib torsional movement, and the rib actually twists from front to back. Remember that living rib has a lot of vitality to it, and it is pliable and will turn quite easily. Just push on your own chest wall and you can feel that. Now that rib torsional movement can become restricted, just like the inhalation and exhalation motions can become restricted. There's a third rib motion that occurs, and that is what happens with the 11th and 12th ribs. And that is that they have what is called caliper motion. On each side, they come back and forth in this fashion, just like the calipers do of your old-fashioned ice tongs, this kind of a motion. So on inhalation, they come back. On exhalation, they move forward. There will be a certain amount of cephalic to caudad motion of the 11th and 12th rib as we do this inhalation, exhalation, as well as this posterior to anterior caliper kind of motion. Now in the rib cage, we have two different kinds of dysfunctions. We have obviously the restriction of respiration itself, and we call those respiratory rib restrictions. Now people can have a lot of respiratory rib restriction without much symptom in the chest wall. So don't expect your patient to present with chest wall pain and say, "Doctor, I have a rib problem." They will not be aware of that, but restriction that you will find of this respiratory movement of inhalation and exhalation is important for that respiratory circulatory aspect. And also, there are a lot of muscles involved in this respiratory effort, both the primary and the accessory muscles of respiration. So that if there's restriction of rib cage motion for whatever reason, it will restrict not only the rib cage, but all of the structures that are related to it. And that's a lot of them, as we've described already. There are other rib cage dysfunctions or rib dysfunctions in which the patient may present to you with a complaint of chest wall pain, intercostal neuralgia type symptom, pleurisy type symptom. "I hurt here, doctor," and you can find some structural rib dysfunctions. That's what we call those. Those in which one or maybe two ribs together have other restrictions in them than just this respiratory, and we will describe those for you subsequently. The key element about those structural ribs are that one, they will restrict respiratory effort, and two, they will be present in the patient who does present with chest wall pain. Think of that first. However, if you don't find one of them and the patient does have chest wall pain, then you better be careful to do other evaluations, neurological and other, to find out, and there might be a more visceral orientation to that chest wall pain. But a structural cause of chest wall pain will be the structural rib dysfunctions. To examine for rib cage function, We started during the screening examination by placing our hands on the lower group and the upper group and simply following inhalation and exhalation. We are interested in both the dynamics of how symmetrical is that inhalation and exhalation, and where is it restricted, and in which phase is it restricted. Is it an upper group? Is it a lower group? Is it inhalation or is it exhalation that is restricted? The other component piece of the diagnostic process of the rib cage is to follow the contours anteriorly along the end of the ribs as they attach to the costochondral junctions. Notice, if you will, that the costochondral junctions from above downward go farther and farther lateral on each side. This costochondral junction is relatively easily palpable. In the presence of rib restriction, particularly a single rib, it is found to be both tender and quite tense and quite tender to our patient. Frequently, this has been described in the past as tsetse syndrome or costochondritis. But in the presence of structural rib dysfunctions, it'll be quite tender and tense to begin with. You treat that rib and that tenderness and tension is gone. Your costochondritis is obviously then not an inflammatory process. We will also do the same posteriorly. We will be interested in the posterior contour of the rib angles from above downward. And notice again, if you will, that they are narrower at the top, and the farther down you go in the rib cage, the wider is the rib angle out. We will be palpating over the rib shaft at the angle, feeling its posterior convexity. We will be interested in its superior border, its inferior border. We will be interested in the inner space above and inner space below, a pair of ribs right to left. The 11th and 12th ribs, because of their atypical nature and the fact that they are buried into the abdominal wall, they will be evaluated in the prone position, and we will be putting our hands in this fashion to feel this caliper motion. Now, how do you know when you're on the 11th and 12th rib? 12th ribs are notoriously asymmetrical, may even be absent. But the 11th rib is quite easily palpable and is pretty consistent. You'll find this free border of the 11th rib just above the middle portion of the iliac crest in the mid-axillary line. And you can palpate that on either side, know where the 11th rib is, work from there medially, and anything below that will then be the 12th rib. I will caution you that the tip of this 11th rib is quite tender in people without any dysfunction of the rib cages. So we will be looking for respiratory activity. That will be our motion test. We will be looking for symmetry of the chest wall by our hand in contact with it. And we will be looking for tissue texture abnormalities, particularly posteriorly along the rib angle, for the insertion of the iliocostalis muscle. And then anteriorly, we'll be interested in tissue texture abnormalities along the costochondral junction for that tenseness and tenderness that it's associated with a single rib restriction. Let us now do this on our patient and examine the rib cage as appropriate. We begin the examination of the ribs looking for respiratory motion and any restriction thereof. We are interested in inhalation and exhalation on the upper ribs and the lower ribs. They seem to function in groups, basically above the 6th rib and below the 6th rib. This appears to be because of the difference in the angle of the attachment of the serratus posterior muscles. The superiors come from obliquely medial to lateral from above downward, and the serratus posterior inferior is just the reverse, and that seems to join somewhere around the 6th rib. To evaluate the lower rib group, we put our hands on the chest wall, symmetrically placed, and get both the anterior and the lateral component so that we can follow inhalation and exhalation of both the pump handle and the bucket handle movement as we do this. The hands should be symmetrically placed either in the inner spaces or on a rib. Now the ribs will move underneath the tissue of the skin and fascia, so I prefer to put my fingers in the interspace so I'm basically following the rib as it moves. We then ask our patient to take a breath in, asking ourselves, is it symmetrical? Blow it out. We're looking both for inhalation, exhalation range, breath in and out, of right side to left side. How symmetrical is that? Does one group of ribs, right or left, stop first during inhalation or stop first in exhalation? If it stops first in exhalation, then it has exhalation restriction. If it stops first in inhalation, it has inhalation restriction. The upper group, we then start by dropping our long finger onto the cartilage of the first rib, just underneath the medial end of the clavicle. We can then display our hands across the upper chest wall in a symmetrical fashion and do the same thing. We ask our patient, breathe deeply in and out. Now in this instance, on the upper group, we now find that our motion is not as symmetrical as it was down here. What do we find? Well, in the first place, when I put my hands on the chest wall, this feels a little more flat. This is a little more rounded, a little more convex. The contour, I got that from the palmar surface of my fingers and the stereognostic sense of the palm of the hand. Secondly, when I had him breathe in and out a little, now back in. See how when he goes back in, let it out. Go up again, breathe in, out a little, now back in hard. The ribs under my left hand here keep moving into inhalation after these have stopped moving in that direction. Therefore, we know that his right upper group of ribs has inhalation restriction because it stopped first. Now let's see what actually happened in exhalation now on this upper group. Take the breath in again. Now blow it all out this time. Force it out for us, Mark. Just a little breath in, little, and then blow hard out. Notice as he forces exhalation, my ribs under my left hand, his right ribs, go farther into exhalation than the ones on this side. Therefore, we know that the ribs on the left upper group have exhalation restriction. They stopped first on exhalation. The ribs on his right side, the upper ribs on the right side, have inhalation restriction because they stopped first on inhalation. That's how we make a diagnosis of inhalation exhalation restriction. It's which group stops first, not which is the maximum range of either of those. So don't think range here, think of which stops first. Now, if we do have, as we do in Mark, some ribs that do not fully go into inhalation, we must find out what is our key rib. Now, what do we mean by key rib? The key rib will be the rib in the group that prevents the rest of the group moving normally. And in his instance, we have an inhalation restriction of this right upper group. Therefore, the key rib will be at the top of that group, because if the top rib cannot go into inhalation, neither can any of the ones below it. The key rib of exhalation restrictions, which he has on his left side, will then be just the reverse. It will be at the bottom of the group, because if the bottom rib cannot go into exhalation, no rib above it can either. So we then need to have a procedure for identifying what is our key rib. Now it's easy with this right upper group because we know it's going to be that first rib. That's our key rib. We'll have to start there to treat his inhalation restriction. But his exhalation restriction over here could be anywhere from 10 on up. So we start and keep looking at our ribs at the medial end of the rib, right near the costochondral junction. And as we come down, you'll notice that these ribs are more cephalward in comparison right to left than the ones on this side over here. Keep coming down. Now that looks more symmetrical than that does. All right, let's start here. There's the 6th rib. Give me a breath in. We'll follow up by pairs now and out. Just one rib at a time, not group. We're looking for a key rib. Breath again and out. Now I find that to be symmetrical on either side. 5th rib. Breath in and out. There we are. Notice that in exhalation, this one does not come down as far as this one on the right side. Breath again. They both go up. Blow it out. And this one keeps moving when this one stops. So our key rib there then is the 5th rib on the left side. That's holding 4, 3, 2, and 1 from going fully into exhalation. That key rib concept is important to recall. Now, let's roll on your stomach for me, Mark, if you will. To evaluate the 11th and 12th ribs, we take the patient into the prone position and identify the 11th and 12th ribs. The 11th rib is easily palpable mid-axillary line just above the mid portion of the iliac crest. So we find the 11th, walk back from there, put our thumbs medial to the 11th and 12th ribs, put our fingers on the 11th and 12th ribs. Now follow respiration. Breathe in and out. Okay, breathe in and out. We're looking for caliper motion as well as the cephalic to caudate motion. Breath in and out. Now what he has is that the ribs on this left side don't fully go into caliper motion down toward the table. The cephalic to caudate looks fairly symmetrical. Breathe in and out. But during exhalation, these ribs on the right side go more into the anterior direction than the ones on the left side. So I have a hunch he has some exhalation restriction of the 11th and 12th ribs on this side. For further evaluation of the ribs, we're interested in that tissue texture abnormality along the rib angle for iliocostalis, because if that is hypertonic, we'll feel that by tension, and it'll be tender to the patient, you can be sure that rib is dysfunctional for some reason. Secondly, we are interested in the contour of those rib angles from above downward. There's a normal posterior convexity, and each rib should participate in that convexity in its own fashion. They all got to participate. Anytime we feel a rib shaft that isn't symmetrical, that calls our attention. We need to do more diagnosis of that particular rib. Now we do this in the prone position, but we also need to look at this contour posteriorly as well as anteriorly with the patient sitting up. So let us sit up first and face toward the right here, if you will. With the patient sitting, I'm interested in the contour of the anterior chest wall at the anterior extremity of the rib at the costochondral junction. I want to make sure that all ribs participate in the anterior convexity from above downward. And as I palpate the costochondral junctions, do I find any of those specifically tense, the tissue around it, or is it tender? So we're looking for contour, tissue reaction in the anterior surface of the chest wall. Now swing your legs across and turn your back to me. I'm interested in the convexity of the chest wall posteriorly as well. The rib angles will start and palpate the most posterior aspect from above downward. And what I'm looking for is the participation of each rib in that contour. If I find one that is not participating as the fellow above and below or to the opposite side, I will give particular attention to that rib. I'm also interested in the tissue reaction and tone of the iliocostalis. And if I find a rib that has either tissue texture reaction or a contour that is abnormal, I will spend a little time on that rib finding out, is it torsioned forward? Is it torsioned backward? Is it missing? Is it more prominent, less prominent in this convexity? What is the tone of the interspace above and below that rib? And is the contour of the interspace above and below the same on this side as it is on this side? Those are some of the diagnostic locations we will look for structural rib dysfunctions. Having identified that the contours are fairly symmetrical and that there is no significant abnormality in that contour front to back, we probably do not have a structural rib problem, and we can proceed to treat the respiratory restrictions which our patient presents for us. However, if we did have a rib that was not in the normal contour, it had abnormal rotation or different contour front to back or a major tissue reaction of it, then we would treat that first. There are certain principles that you need to have in mind when you treat inhalation and exhalation restrictions, and we'll give you those as we treat his inhalation restriction on the right upper group and the exhalation restriction on the left upper group. The principles of treatment for inhalation restriction of rib groups is as follows. We have one, we're going to want to disengage the rib head by pulling the rib laterally and caudad from the posterior aspect. Two, we're going to ask the patient to provide an inhalation effort which starts the ribs into inhalation to the barrier. And then we're going to activate a muscle group to lift the rib into inhalation. We have three muscle groups that we will use. The first is a scalene group that will elevate the first and second rib. The second muscle is the pectoralis minor and some fibers of the major, but primarily the minor, to treat ribs 3, 4, and 5. And then we will use the serratus anterior for 6, 7, 8, and 9. The principle of treating inhalation restriction is that you start from the top because that's where your key rib is. So we will start on to treat ribs inhalation restrictions of his upper group, starting at the first rib. Now, finding the first rib and second rib is not quite as easy as it might sound. But an easy way to do it is to find the vertebral prominence, C7, the spinous process. That's easily palpable. Go one down, that's T1, and at that level is the transverse process of T1, and just beyond that little knobby transverse process, you can get a hold of the first rib and the second rib. And we will pull it laterally and in a caudad direction, distracting the rib heads of 1 and 2 as best we can from their facets on the vertebral bodies. Then what we will do is we will control the patient's head and neck so that we can put the scalene muscles on stretch, have him take a deep breath in, and then activate that by head movement. Let us see how that goes on our patient. We start by rolling him to us so that we can identify the vertebral prominence, first transverse process, and just lateral to that is the first rib. There's the first rib, and there's the second rib just below it. We will grasp those as best we can to take bone, distract it, and pull caudad. We do this with the patient back on the table, square, pull laterally and caudad. Now we will turn his head, left rotation, left side bending, to put the scalene muscles on stretch. Take a deep breath in, Mark. Lift your head off the table. Lift straight up. Relax. And you'll notice that the scalene muscles contract when I ask him to flex his head. That will deal primarily with the pump handle component. Deep breath in. Now push your right ear to your right shoulder and relax. That's a side bending component which will deal more with the bucket handle movement of this first and second rib. I'm constantly pulling laterally and caudad with my hand underneath him. Deep breath in again. Lift your head off the table, lift straight up, and stop. Usually 3 efforts are enough to restore inhalation movement to the first and second rib. To deal with 3, 4, and 5, we just pull him forward, move our hands down, 3rd, 4th, and 5th rib, pull laterally and caudad. Now we're going to put the pectoralis minor on stretch. Have him take a deep breath in again, deep breath. Push the elbow straight forward in my hand. That will be a pump handle movement. Relax, let your breath out. Deep breath in again. Push your elbow to the right. That will deal more with the bucket handle component. Relax. And one more time, deep breath in. Push that elbow in my hand. Push. And relax. Now, if you have a patient with shoulder problems, a frozen shoulder, and it's not possible to put that arm in that position, you can still activate the pectoralis minor by hooking your thumb under the coracoid process. Your hand right here, Mark. Coracoid process. Deep breath in. Now push that shoulder into my thumb. Relax. We're still stabilizing the scapular attachment of the pec minor, and it'll still lift that rib into inhalation for us. For ribs 6, 7, 8, and 9, we pull laterally and caudad. Take his arm up and over his head. Put the serratus anterior on stretch. Deep breath in. Pull your elbow forward. That activates a pump handle motion of the lower ribs. Relax. Deep breath in. Now pull your elbow to the right, and that activates it in a bucket handle fashion. Relax. So that we can treat ribs 1 and 2 with the scalenes, 3, 4, and 5, pec minor, the rest of them with the serratus anterior. Those are the principles of inhalation restriction. The principles of treatment of exhalation restriction are the following. 1, we will use the body position of flexion, side bending toward the side of restriction, so that that body position will take our ribs into exhalation direction, engage our barrier that way. The second principle is we will use our thumb and thenar eminence in contact with the superior aspect of the rib shaft and spanning the costochondral junction in this fashion to hold the rib in an exhalation position. We do not push it down. This hand contact will hold the rib as we get it into a position of exhalation against its barrier. The third will be the use of the patient's exhalation effort. As they exhale and we follow and resist an inhalation effort, we are keeping the rib from coming into inhalation, and then we can take it farther into exhalation. On our patient, it will look like the following. Recall that Mark has exhalation restriction of the left upper rib group, and we found the key rib at the bottom to have been the 5th rib. So we will want to identify the 5th rib and its costochondral junction, so that we will put our thumb, thenar eminence, along the superior aspect of the shaft, and you span the costochondral junction to protect it. You don't want to separate it. It is sensitive at that point and can be separated if you're only out on the rib and do not include the cartilage under your thumb. This hand will control his whole upper trunk and neck. But I want to make sure that we have the thoracic spine and not just use his head as the lever arm to do this. So this arm goes underneath, control his trunk. Now, by flexion, I'm engaging the pump handle component, and by side bending 2, I engage the bucket handle component. Follow it till I feel the barrier. Give me a breath in, blow it all out. As it goes out, I follow it with body position and hold with my thumb. Breath in again. I resist inhalation effort. Blow it out again. Notice I'm not pushing down with my thumb, I'm holding. Breath again. And out. Constantly finding the new barrier. One more time. And out. Now I hold that rib in that position, return his trunk back into neutral. Now I ask him to have one more breath. Breathe in. It's attempting to lift it up, and I don't let it happen. Let it out. Now I will release slowly. I don't want to take my hand off in a rapid fashion because that will cause the intercostals above that rib to grab down quickly. The only difference between the upper group and the lower group will be where you contact the superior shaft of the rib. Remember that the costochondral junction goes more laterally as you go from above downward. Find your key rib, contact it. Now we will put more side bending and less flexion in, still following the inhalation-exhalation efforts 3 to 4 times. Return to neutral, and then release slowly. In the treatment of exhalation restrictions, you would start from the bottom and work up. In Mark's instance, we did not find exhalation restriction in the bottom. We could start with the upper group with the key rib at 5. But the basic principle would be you always work from the bottom up with exhalation restrictions. Now, Mark, if you'll roll over on your stomach for me. During the examination process, we found that Mark had, put the hands on the table for me, thank you. Mark had exhalation restriction of the 11th and 12th ribs on the left side. So we will want to design a procedure using the same principles of respiratory effort, body position, and some muscle action to move the 11th and 12th rib into an exhalation position. We will do that on this left side by putting our hand on the medial side of these rib angles, and I'm going to scoop them laterally, scoop laterally. The hand goes here and scoops laterally. We'll find the 11th and the 12th rib. Put the thenar and hypothenar remnants medial to the angles of the 11th and 12th ribs. We're going to scoop them laterally. That disengages the head. Then if I want to take it into inhalation, I can move them in a cephalic direction. If I want to take it into exhalation, I take it in a caudad direction. But the scooping maneuver of this distraction is present in both techniques. In Mark's case, we have exhalation restriction. So we want to take it into exhalation. We will enhance that then by a body position of side bending him to that side. That starts these ribs into exhalation. I will scoop the rib out, take it caudad. Notice that my arm is above the contact on the rib, taking it in a caudad direction. I reach over and grab his anterior superior iliac spine. Okay, Mark, take a breath in, blow it all out. That's the exhalation component. I'm guiding it into exhalation. Lift up his anterior superior iliac spine. Now pull this hip down toward the table. Pull it down. That activates the muscles of the abdominal wall posteriorly and moves the rib in the direction I'm holding it. Relax. Breath again, in and out. One more pull down toward the table. Muscle action. And out. Breathe. And out. One more time. Pull that down. Relax. We have used operator guiding, respiratory action, and muscle effort. Now, had this been an inhalation restriction, we would have started exactly where we did, except now we would change his body position. Put your arm up over your head, and I'm going to side bend him to the right to enhance the capacity of that rib to go into inhalation. My distraction maneuver is the same, but now I'm going to take it in a cephalic direction. Again, hold the anterior superior iliac spine. Take a deep breath in, hold it in, now pull that hip down. Relax. Once more, a breath in and pull the hip down. Relax. The common element is the contraction of the abdominal musculature. How we change the inhalation to exhalation maneuver is the direction of operator guiding, the patient's position, and the respiratory effort. Again, after every technique of this type, we will go back and reevaluate the 11th and 12th ribs for inhalation, exhalation, restriction. In the treatment of an exhalation restriction of the first rib, we need to be above the clavicle. The first rib is only palpable by its cartilage underneath the medial end of the clavicle. The first rib can have exhalation restriction in and of itself. You can say about the first rib that it can do almost anything it wants to. So we're going to want to palpate on the superior aspect of the first rib, both just posterior to the medial end of the clavicle to contact it for pump handle restriction, and the lateral aspect for bucket handle. Now you want to stay away from the neurovascular bundle, which lays over top of the first rib in about this fashion. So we'll place a thumb on the anterior and lateral aspect of the first rib, anterior to and posterior to the neurovascular bundle. On our patient, we will take and control his head and then make a contact on the first rib. If we have more pump handle, we will be anterior to the neurovascular bundle. If we have more bucket handle, we will be behind the neurovascular bundle, which lies approximately there. We'll be back here on the lateral aspect of the rib, just in front of the trapezius muscle. We will use respiratory effort, body position, and a hold with this thumb, holding the rib in the exhalation position. For pump handle, we work our thumb either lateral to or between the two heads of the sternomastoid muscle till we come in contact with the first rib. Flex his head, side bend it to, take the tension off of the tissues above, and that starts the rib into exhalation movement. The first barrier we find, we stop there. Give me a breath in, Mark, and breathe out. As he breathes out, I follow with flexion of the head, and my thumb now follows the rib into exhalation. Hold it there. Breath in again, and out. Follow the disappearing thumb. Breathe in and out. 3 to 4 efforts. We hold it there, return the head back to neutral. It's very important to be very careful when you put your thumb in contact, because it's extremely sensitive tissue and you want to be gentle but firm with your contact of the thumb. Had he had more bucket handle movement, restriction, we would have placed the thumb laterally on the superior aspect of the shaft of the rib, put more side bending in than flexion. Breath in and out. Breath in again and out. We don't let it come in with each inhalation effort and follow the exhalation effort. Again, follow the disappearing thumb. Breath again and out. Hold it there and then return his head back to neutral and release the pressure on the first rib gently. Always go back and reevaluate the first rib for its respiratory capability, and you do that by reaching around in front, getting a hold of the medial end of the first rib cartilage just below the medial end of the clavicle. Breath in and out. The structural rib dysfunctions are several. The first we will describe for you are what are called subluxations, and that is when the rib head, costovertebral, and the costotransverse articulations, for some reason or other, usually trauma, have become hypermobile and allowed the rib to slide posterolaterally along the axis of the costovertebral and the costotransverse, or to have been pushed forward with the rib going more anteriorly in relationship to those two joints. These are traumatic lesions following sports injury, motor vehicle accidents, and what happens is a single rib will slide posterolaterally or anteroposteriorly. Now, the difference in that is as follows. If the rib comes posteriorly, the rib angle becomes prominent posteriorly. That's your first clue diagnostically. There will be a prominence to the rib posteriorly, but anteriorly, that same rib in front will be less prominent in the anterior convexity. What we will want to do then is design a procedure which will allow us to push this rib back in an anteromedial direction to restore its function. So posterior subluxations, the rib angle is posterior. We will begin the treatment by putting our thumb in contact with the rib angle lateral to it. So the iliocostalis will be here. So we're lateral to the rib angle, and we will exert a force on the rib on an anteromedial direction. Then we will ask the patient to contract muscles of the shoulder girdle to move this rib for us. On our patient, we are going to simulate this at the 7th rib. Mark, fortunately, does not have a posterior subluxation. We'll begin by having him take his left arm, his right arm, that's this one here, and hold his left shoulder. Now we can use this arm and muscle action that he will provide for us to move this rib. We find our dysfunctional rib, put our thumb on the rib shaft lateral to the angle, and maintain a compressive force anteromedially. Now I will elevate and depress his elbow until I localize to that rib. The higher the rib, the higher the elbow. The lower the rib, the lower the elbow. Now I will be maintaining a pushing force anteromedially, and I will instruct Mark, push your elbow into my hand. Push into my hand, and stop. Push your elbow to the ceiling. Push it up. Stop. Push the elbow into my hand again. Push and stop. Constantly I have a pressure with this thumb going anteromedially. The pushing effort of the elbow into my hand or toward the ceiling attempts to take the rib posteriorly, and I don't let that happen. And I constantly am working the rib in an anteromedial direction. The anterior subluxation is when the rib has slid forward in relationship to the costovertebral to costotransverse. In this instance, I want to develop a technique that will pull it backward for me, posterolaterally. My thumb contact now is on the rib shaft between the costotransverse articulation and the angle. So I will work my thumb into there, get as much contact with the bone as I can, and pull posterolaterally on this rib shaft in that direction, and then again use the elbow effort to pull the rib posterolaterally. All right, take that hand and hold that left shoulder again. Now we find the rib shaft, here's the angle, the rib shaft medial to the angle, work through the fascial plane of the iliocostalis to the longissimus, get to the rib shaft, and I'm going to start a posterolateral pulling maneuver with my thumb. Again, localize with the elbow. When I find that localization, put a posterolateral pull on that. Now pull your elbow to the right. Pull it right. Relax. pull your elbow down to the lap. Pull it straight down. Relax. I'm constantly pulling posterolaterally with my thumb as he pulls his elbow to the right or pulls it to the lap. Notice the pull-pull relationship, just the reverse of what we had on the posterior subluxation, which was push-push. All right, one more. Pull to the right now for me. Pull and relax. This combined muscle action and operator guiding will allow you to take a subluxed rib, either that's posterior, push it forward. If it's anterior, pull it back. You need to restore function to subluxed ribs in order for them to have normal rib motion from the respiratory perspective. These rib subluxations are key ribs as restrictors of respiration. They are very tender, so you'll be very careful about these. There will be some traumatic history, sports injuries or motor vehicle accidents or something of that nature. Another rib subluxation can occur on the first rib, and that is a superior subluxation. That can happen at the first rib because it has a unifacet and can move more freely than some of the typical ribs below. If there has been trauma that acutely lifts up the first rib by left side bending of the cervical spine, and if the rib gets caught on top of the transverse process of T1, it is held in a superior subluxed position. Obviously, you would expect exhalation restriction as well, and that is true. So if you get an exhalation restriction that doesn't treat, think of a superior subluxation. What has happened is that one first rib is higher than the other, about the width of the transverse process. That's about 1/4 of an inch. To make the diagnosis, we will pull the trapezius muscles posteriorly and drop our fingers down on top of the first rib. And if we find one is 1/4 of an inch high, we know that that is a subluxation. If we find that the right rib is high by that much and major restriction of motion of that right first rib, we will want to then develop a technique to take it down into its normal relationship or push it down. We will do that by pulling that trapezius muscle posteriorly, putting a finger contact on the superior aspect of the first rib. Our thumb will go behind the trap and push through the trap to push this rib forward sufficiently to get it off of the transverse process and allow it to drop down. Now, superior rib subluxations also have tightness of the scalenes on that side, so we want to stretch the scalene, and we will inhibit this right scalene by activating the one on the left side. Let us see how that occurs on our patient. Diagnostically, we begin by putting our fingers in front of the trapezius, pulling posteriorly, and dropping our fingers on top of the shaft of the first rib posteriorly. Fortunately, our patient does not have one, but if he had one on the right side, what would happen is this finger on the right side would run into a resistance before the one on the left. And if it is 1/4 of an inch high, major respiratory restriction, we've made our diagnosis. To treat this, we will pull that trap back, put a contact on the posterior shaft of the rib. This thumb goes behind the trapezius, so we have the first rib under control in my right hand. My left hand is going to control his head and neck. We will side bend him to, rotate him to, reducing the tension on these right scalenes. Push with our thumb anteriorly, then inferiorly with the shaft. Push your left ear left. That activates the left scalenes, inhibits the right. Stop. Push forward, keep it going down. Push left again. Relax. And one more time. Relax. Square him up. Retest by pulling the trap back and going down on the superior aspect. You should have restored symmetry right to left. The structural rib dysfunction, termed torsional rib restriction, is the restricted movement of a rib that occurs when the trunk rotates right to left. We described that for you earlier, and as you turn to the right ribs will externally torsion themselves, with the superior border being sharp and the inferior border being less sharp, and concurrently the left ribs will torsion internally, with the superior border being much less sharp but the inferior border becoming quite sharp. Those can become restricted, particularly with your non-neutral dysfunctions of the thoracic spine, particularly the ERS dysfunctions, extended, side-bent, rotated right thoracic dysfunction. That externally torsions the rib, and if that ERS dysfunction has been there sufficient time, the rib will maintain itself as externally torsioned and will not go into its normal relationship. Fortunately, these usually will treat out, the rib component will treat out when you treat your ERS dysfunction. But if it does not, then you must go back and treat the rib individually. Now, how this will be done is that we will put a contact point on the angle of the rib with our thumb placed vertically over the posterior convexity of the rib angle. If the rib has externally torsioned and the superior border is sharp, we will attempt to guide it forward, the superior border forward, returning the rib to its normal relationship. If it was internally torsioned, and they're much less common, we will put our thumb and put compressive force on the sharp inferior border, attempting to turn it more into its normal relationship. We will again use muscle effort of the patient's arm as we did in the subluxations. In the treatment of a rib torsion, we will find our torsioned rib and find the rib angle of that and put our thumb on the posterior convexity. Let me have that right hand hold the left shoulder again. The external torsion I'm going to push in this direction, guiding the rib into internal torsional movement. If it's an internal restriction, internal torsion, I will be on the superior aspect and put my pressure in that direction. Again, we will control the patient's right arm, as we did in the subluxations, identify and localize to it. For an external torsion, I will put my compressive force on the superior aspect of that rib. Now, push your elbow up to the ceiling, pull it down to the floor. Up to the ceiling, down to the floor. Up to the ceiling, down to the floor. We do a series of repetitions of this elevation depression, and each time his shoulder muscles are activated, that will rotate the rib in and out in this fashion. As I'm guiding the rib internally torsioned, that motion internal, it keeps moving in the direction we want it to be. If we had an internal torsion, the only difference would be I will now put the compressive force on the bottom side of the rib. Lift your elbow up, down, pull down, push up, push down, constantly guiding the rib into an external torsional movement. Again, after any treatment, we would go back and reevaluate whether or not we had restored function to that torsioned rib. Torsion ribs are also important because they are frequently the key rib of respiratory rib restriction, either inhalation or exhalation, and those should be treated if present before you address your respiratory rib restrictions. Another structural rib dysfunction, and this is a true interosseous dysfunction of the rib, occurs during a trauma in which the rib cage is compressed anteroposteriorly. Now normally, as the rib cage gets compressed, when that force is released, the ribs spring back to their normal contour. In certain traumas, the rib compression can occur and 1 or 2 ribs will be held in that position. It's actually within the bone itself. It's compressed, restricted anteriorly and posteriorly. Now, the physical findings of that would be that that rib would not be prominent in the posterior convexity, not prominent in the anterior convexity, but as you palpate in the mid-axillary line on each side, you would find that that rib, or 2 or 3 if more than one is involved, would be more prominent. They're usually a single rib, and you just feel in the mid-axillary line and it's very prominent there. Therefore, what you want to do is to reduce that antero-posterior compression, and we do that by making a contact with our hands in this fashion, across the long fingers over that prominent rib in the mid-axillary line, and have a medial compressive force on it. We will then ask the patient to take a deep breath that attempts to expand that rib. We'll hold it on its mid-axillary line. It'll move antero-posteriorly, and then to do a side bending effort to the opposite side simultaneously. Diagnostically, on our patient, we would find this by finding a rib missing in the posterior aspect, a rib missing in the anterior convexity. It will be tender. There'll be reactions of the iliocostalis, and then as we palpate the mid-axillary, we'll find that rib to be prominent. Finding an antero-posteriorly compressed rib, we will treat it by the following fashion. Put your left arm over my shoulder, just let it drop. Now what I'm going to do is put a contact on the dysfunctional rib with one finger from in front and one from behind. Notice that my posterior hand is more superior than the anterior hand. That's because of the contour of the rib. I'm going to put a compressive force on that and maintain that. Side bend our patient to that side. Hold that while I ask him to take a breath in, breathe in, and lean to the left. Lean down into my shoulder. Relax. Keep the compression. Deep breath in. Hold that. Now lean left. Relax. The end result of that is that the rib springs out antero-posteriorly because I've got a compressive force on a medial direction. Again, returning to reevaluation of contour, respiratory capabilities, and reduction in the tension of the iliocostalis muscle at the angle will tell us that we restored function to that rib compression. Rib compressions also are those that can interfere with the respiratory motion of the chest wall. Another structural rib dysfunction occurs following trauma which will introduce an abnormal motion for a rib. Now, as we described before, ribs will go into inhalation and exhalation with both pump handle and bucket handle movement. Now, the bucket handle we described is the lateral excursion of the rib. But during that, the front aspect of it is always moving laterally. So it isn't a true bucket handle. However, if you get an acute side-bending injury to the trunk, to either side, what that can do is artificially induce a lateral flexion, most times up, occasionally down, but most of them are laterally flexed up because we've established an anterior-posterior axis for that rib to do that with the acute trunk side bending. Then when the trunk comes back up, if the rib doesn't have the capacity to go back into its normal respiratory movement, we have trouble. When this occurs up as far as the second rib, and that is not uncommon because of the attachment of the scalenes to the second rib, it can have a devastating effect on the functional capability of the neurovascular bundle as it goes down the arm. And a lot of patients with this problem will present with arm pain, numbness, tingling, and even to some of the vascular changes in pulses because of the compression of this first rib at the costoclavicular canal. You would make the diagnosis first by the index of suspicion from the history and the persistence of disabling symptoms. Secondly, there would be exhalation restriction of that rib if it was a laterally flexed up, and that's the most common. And as you palpated this mid-axillary line, you would find that again a rib was more prominent than it should be in that mid-axillary line, and it would have major exhalation restriction. Once a diagnosis is made, the treatment procedure will be as follows. We will put a hand on the lateral chest wall and slide it up in the mid-axillary line until we find our dysfunctional rib. Side bend the patient's trunk to that side to allow the rib to go downward. Exhalation effort, again, to take the rib down several times until we are sure we are above our dysfunctional rib. At that point, when the patient has an exhalation effort, we will turn our fingers, hook them over that dysfunctional rib to hold it there, and then we restore the patient back to midline and then release slowly here. For demonstration purposes, we're going to do this to the fourth rib, but I will show you that it is possible to get up in that axilla sufficiently to get above that second rib, and then you can hold it in that fashion there as you return the head up. That is exquisitely tender territory. In a normal patient, if they have dysfunction of the second rib that's laterally flexed up, it is even more acutely tender and will need a great deal of gentleness on your part. On our patient, we're going to do this simulating that the fourth rib is laterally flexed up. We want to pull it down so then it can do its more normal respiratory movement. We place our hand on the lateral chest wall so that we can slide cephalward toward the axilla. We then ask our patient to reach down toward the knee with his hand, and I side bend his trunk to that side. Give me a breath in and out, and as he blows out, I side bend him a little more. Reach down with your hand, fine, relax. My fingers are now going more cephalward to be above that fourth rib. 2 or 3 efforts sufficient to get above that rib with your fingers. Then I will hook that rib and straighten him back up and relax gently. Return for diagnosis again to see that if it's mobile and that it is no longer as prominent in the mid-axillary line as it was prior to that. Occasionally, you do not get response to your rib treatment with the muscle energy respiratory assist techniques. In that case, a high-velocity procedure might be helpful. A high-velocity procedure for the typical ribs will be as follows. If we have an inhalation or exhalation restriction, we will treat them with just a difference in the hand placement. We will modify our thoracic high-velocity technique in the supine position to make it a rib technique, and we do it in the following fashion. We will establish our fulcrum at the rib angle. We will establish our lever arm, again by using the arms crossed, doubly, singly, whatever seems to work the best. And if we have a rib that has exhalation restriction, we will want to take the posterior aspect at the rib angle cephalward so that it'll go into exhalation. Therefore, we would get below that rib shaft with our thumb thenar eminence and provide a force going cephalward in that fashion. If the rib had inhalation restriction, we would change our hand and put it on top of the rib shaft at the angle and direct the rib caudad with our thumb moving in that direction. we will localize our lever arm to our fulcrum on that rib, and at the time of the epigastric thrust to the fulcrum, we will move the thumb whichever direction we wish it to go. We begin by establishing our lever arm, crossing the arms over, and now I wish to place my fulcrum on the rib. The hand placement will be that for a rib that has exhalation restriction. We will get on the inferior shaft of the rib, contact it there, and my hand force will be going cephalward in that torsional movement. Once I establish the contact, put the patient back on the table, and now I take and localize my lever arm to the fulcrum, and I'm over the rib angle, not over the midline as you are with thoracic spine, but over that rib angle. I put the compressive force in a cephalic direction. Breathe in and all out. And then the force goes with the epigastric thrust to the fulcrum. For a rib that restricts inhalation, we would again, same principle of establishing our lever arm. Our fulcrum now will start with the thumb on the superior aspect of the rib, and I will take it in this direction with my thumb. Get a contact back to the midline, over the rib angle with our lever arm. Force that way. Take a breath in and put the epigastric thrust at inhalation this time. So we get a respiratory assist, a movement on the rib angle with our thumb, and the application of the epigastric thrust to the rib. The first rib can be treated with high velocity for both inhalation and exhalation restriction. It can be done in the supine position quite easily, and it is done in the following fashion. We will treat the right first rib. To do that, we slide our arm under the left axilla, put our hand behind the patient with our finger pads on top of the superior shaft of the first rib in front of the trapezius. That gives us the capacity to take it forward or backward, depending upon whether we want to take it into exhalation or inhalation. We will then use the head and neck in neutral mechanics, of side bending 2, rotating away, in order to move the unifacet of the first rib, the rib head on the unifacet of T1. And we'll use a thrusting maneuver either with the head and neck or a pull with the hand on the shaft of the rib. We want to articulate the rib head at the unifacet. On our patient, we will start underneath this axilla, slide our hand under so we can reach across to the right cervical-thoracic junction, take the trapezius muscle out of the way, and put our fingers on the superior shaft. I want to take it into exhalation, I roll it forward. Inhalation, I roll it backward. Get the contact, roll it backward for inhalation. That's more common on the right side, so we will do that. So we're going to take it into inhalation. I control the head and neck. Side bend 2, rotate away the head, down to localize at the cervical-thoracic junction. And then it's an exaggeration of the head and neck as a lever arm to move the rib head away from the unifacet on the side of T1. In the treatment sequence of the patient, you would start by treating the lower part of the trunk, the lumbar spine and the pelvis, then proceed to treat the thoracic spine, and then evaluate and treat ribs if they are dysfunctional. In rib dysfunctions, we gave you both the respiratory restrictions of inhalation and exhalation, as well as single rib restrictions that we called structural rib restrictions. The subluxations, anterior, posterior, superior, the lateral compression, the torsion, and the lateral flexion. Only the compression is a true structural interosseous problem. The rest of them are motion restrictions. But each of those structural ribs are very significant in the respiratory restriction because they can become key ribs. So you're interested in finding those to treat those before treating respiratory ribs. Those single rib restrictions, those structural rib restrictions, are also commonly present in patients with chest wall pain. Evaluation and treatment of those should give the patient some response for that complaint. If, however, you find one and treat it and the chest wall pain is not relieved, you should then proceed to do other evaluations to look for organic causes. Neurologic ones like herpes zoster, spinal cord tumor, internal thoracic things, pulmonary, and others of that nature. But you want to try to restore maximum capacity of the rib cage for its influence on respiration and circulation and the effect that it has on the diaphragm.
2 times.